Okay, so welcome everybody. It's an honor for us to have Dr. Juan Carlos Puyana today. Thank you very much for accepting our invitation. We're so happy to have you here. This is a very interesting topic, especially for people like me that it's kind of new in the surgical world. So thank you, Dr. Puyana, and please, if you can introduce yourself and let us know a little bit more about you. For the ones that doesn't know you, that would be amazing. Thank you.
Thank you, Carolina. It's a pleasure to be here, and I appreciate the invitation. It's also an honor to become more active within the G4 Alliance, which is an organization that I had been looking for a long time, but now that I am more connected to the world of global surgery through the Royal College of Surgeons in Ireland, I'm excited to play a more active role in all the activities that the G4 Alliance has been so effective in organizing and advocating. When I was asked to present to this group, I was excited, one, because it's to the Latin American chapter, and I have my heart there since I'm originally from Colombia. And also because I'm a trauma surgeon, and that's how I started my global surgery work, through trauma. And I think that's a good part of what I will be talking about today, just because that is very relevant to the Latin American reality. I'm a surgeon. I was going to talk a little bit about myself on the third or fourth slide. So maybe I'll move into my lecture. My current job is I am now in charge of the Institute of Global Surgery in Dublin at the Royal College of Surgeons in Ireland. And through that new job, I'm learning tremendous amount of things about global health that I'm totally excited to be leading. And I also maintain some of my research activities at the University of Pittsburgh, where I had been successfully engaged in global health research for a long time. So I will talk a little bit about all those things, but I'll move on and share with you what I think is an important subject, and that is that there were a lot of activities related to global surgery that were not called that way. I think one of the greatest things we owe to the Lancet Commission is the ability to have a common language. And I sometimes say that the Lancet Commission is to global surgery what ATLS is to trauma. It allows us to come up with a common language that everybody understands. But it's just the beginning of what I think is quite a tremendous challenge. Teaching ATLS around the world is what ATLS was most good at it. Providing access to surgical care around the world is a tremendous task, and the Lancet Commission has allowed us to begin that effort. At the center of global surgery is the word essential surgery, because essential means something different depending on where the context is. So I like the word essential because essential forces to think on the surgical axis and the surgical care that is required in the places where we are working. We need to be experts about where are we improving access to care, and it's different from one place to another. So my job today, starting from the Lancet Commission, is to back a little bit behind and see what was going on before that. Clearly, we were able to see that there were a tremendous disparity in access to surgery over the world, and we owe the measurement of that, and somehow, to the data that came out through the report that took several years to come out. And then we were able to understand the tremendous magnitude of the global of surgical conditions that if people in the world, we have access to that, we will diminish tremendously the amount of disability and save a lot of lives. So everybody here understands that. I'm not going to spend time on showing data from the Lancet Commission. We use it all the time to talk about it. Clearly, there were 3 documents that were fundamental. They all came at the same time. All the people in this room is familiar with these documents. But that gave a tremendous foundation for everything else that happened after the Lancet Commission. So what was there before? Well, I went to ask to the God of all knowledge right now. I asked GPT in the chat to tell me what was going on before the Lancet Commission, and Chat GPT came with these answers. If you look at these, there are many organizations and a lot of activities that have been tremendously successful providing surgical care around the world before the Lancet Commission. Each and every one of them have a specific aim. And I'm not going to dwell into this, but there was a tremendous amount of work that was present there, some of it quite old, from 1960s and 1970s, to more recent innovations, to more recent NGOs, that all provided some sort of training, some sort of education, some sort of advocacy in advancing surgical care around the world. And this is just a list of perhaps the most important ones, the ones that I was able to obtain in a number of questions that I was playing with when I accessed ChatGPT about these issues. But I'm going to concentrate today a little bit more in detail about the role of the trauma surgeon in global health. Why? Well, because I happen to be a trauma surgeon, and I believe that is one of those essential surgeries that is essential for places where violence and injuries are the most prevalent burden of disease. And unfortunately, that is the reality in many countries in Latin America, and that's why we have become experts in an area that which we were not experts on it. I was born in Colombia, and as a medical student in Colombia, I saw injuries and violence from the very beginning because of the reality of what has been a society characterized by violence for many years. In medical school, we were on call every night seeing trauma patients coming in every one of our inner city hospitals, and we didn't have what it was needed to provide care for these patients. You heard Sabrina's studious reality of Guatemala when she gave the introduction to the meeting from the Global Surgery Foundation at WHO last week. Sabrina is one of my students, and she has the same experience taking care of trauma patients in Guatemala. I went to medical school in Colombia. I did my residency in Montreal. During my time in Montreal, I saw 2 gunshot wounds during 6 years. That's because Canadians are more civilized than most of other people in America and all the Americas. So it was tremendously important for me to train in trauma. I was planning to go back to Colombia after finishing my residency, but I didn't. I actually went to the United States. I did a fellowship in trauma, and then I never returned. So I'm a little bit of a global surgeon myself, a little bit of a hybrid surgeon. And this is my mentor, the professor of surgery that allowed me to train in Canada. And when I told him that I was going to the States to do my fellowship, he got mad at me. He said to me, if you go to the States, you'll never go back to Colombia. He always made me feel guilty about that. And that's one of the reasons why I started to work on global health, looking into trauma and thinking about what is it in my career, the things that I do, that I could turn into global surgery. And this is just a slide of a tremendous dynamic interaction between your profession, the thing that you do, and how you can convert that into improving access to surgery in an essential place. As a trauma surgeon, I began to look into possibilities to develop access to trauma care in places where it was most needed. So over the years, we were successful in obtaining grants and training people. So we thought that, as many other options, trauma care is perhaps one of the areas where a surgeon interested in global health can actually develop and provide tremendous amount of service to humanity. So it is also important to see that as a surgeon dedicated to trauma, you get to know a lot about the global aspects of global surgery. On the left are the trauma rooms that we visited during many years in Latin America, from Guatemala to Buenos Aires, and we were able to see the tremendous disparities, the tremendous challenges and lack of access, and having supplies, infrastructure, trained surgeons, resuscitation techniques, all the things that we thought should be prevalent and should be available in places where trauma is such an incredible public health issue. And then we come back to Pittsburgh, where I worked over the last 22 years, and the ability to be able to see how different in each one of these places will allow us to understand better how to create programs, how to develop opportunities for training, for cross fertilization, for interaction, for collaboration, and for reciprocal activities between trauma surgeons in the United States at the University of Pittsburgh and trauma surgeons in Latin America. That was the context in which we developed our global health experience. And a lot of these things happen before the Lancet Commission, perhaps because of the crisis that we were seeing in Latin America. One of the most striking statistics that one can read is that I think that 20 of the most dangerous cities in the world are in Latin America. And even though this slide keeps changing, the changes only happen within the same regions in Latin America. One year, the worst city in the world is Caracas. The next year, the worst city in the world is Honduras. And they keep sort of bouncing back and forth. Brazil has probably 5 or 6 of the cities with the highest homicide rate in the world right now. So the burden of disease due to violence is perhaps one of the greatest challenges that as a trauma surgeon needs to face in global health. And going back to the title of the talk, how do you do global health before the Lancet Commission when you are facing these kind of problems? Well, we did it through the surgical societies. And I'll spend a few minutes telling you about the tremendous role that the Pan American Trauma Society had all over Latin America because of global health interactions, international collaborations, and a real sort of commitment to participate with common goals across the challenges that trauma surgeons were facing in Latin America. So for the young people in the audience, I think it's vital to see that going through the professional societies led by surgeons is one of the options for you to get engaged in global health, for you to learn about the realities of global surgery. And I'll give you a few examples of that. Before I go in detail with the Pan American Trauma Society, I need to stop here and make a little pause and tell you what I'm learning about another example of a tremendous effective collaboration between 2 professional societies. And those are the one from the Royal College of Surgeons in Ireland and COSEXA in Africa. And although I'm not going to spend a lot of time in these, and I'm just new at my job, I've only been in Dublin for a month, and I don't claim to have taken part of any of the tremendous success that these 2 surgical societies participated. I will share a few slides of the tremendous impact in global health that these professional institutions and these professional societies began and how they grew so fast and so effectively. It all starts with a personal relationship. A professor at the Royal College, Gerald O'Sullivan, and a professor in Ethiopia, Krikor Ersiganstian, began what it was a personal connection because they both were trained in Dublin when they were young residents in surgery. Many years later, they began working together and help each other and help professional societies on both sides. Today, COSEXA is perhaps one of the greatest examples of these global initiatives where training, where mutual collaborations, where profound interactions and education activities have an impact that has gone beyond many countries. It is clear for those interested, the impact of COSEXA in developing the workforce in Africa is one of the most amazing things that COSEXA has accomplished, and the exponential growth of professionals over the time, graduates and people that were examined and certified from many countries, female surgeons. It's an amazing example of how professional societies began something tiny that becomes a national and international power force in improving surgical access to care. This is a rather old slide, but it is likely that by now it's probably twice as the number of operations. These interactions and this education has trained people, and they have operated close to 500,000 operations in all these many countries throughout these 15 years. And this is one of the most striking examples of effective global health collaborations in surgery. Let me go back to the Pan American, because I think this is something that I'm more familiar with, that I am that I've been working on for the last 30 years with the society, and that we felt is something that we're very proud about, the work that the Pan American Trauma Society did for global health in trauma, as COSEXA has done for global health in Africa. Let me give you the most simple example. For those who are not surgeons, may not know what the Bogota bag means, but for those who have been dealing with trauma patients, the Bogota bag is one of those things where surgeons from a country in high need of care, with a country that was going through a major crisis due to violence in the 80s and 90s of last century, introduce a new technique to do damage control by putting these plastic bag in patients with damage control resuscitation. The person who created this was Osvaldo Borraes, who's a personal friend of mine. And Borraes was sort of the inventor of the Bogota bag, but the person who put the name of the Bogota bag on the paper was Dr. Feliciano, who went to Colombia to visit one of these hospitals, and Borraes told him about how to use the Bogota bag for damage control. So this is one of those examples where surgeons from places where they have a lot of resources actually end up learning tricks and techniques and alternatives of operations that are learned in places where perhaps the resources are more constrained. This is another example. This is something I learned when I visit Caracas. If you look at the ATLS manual, no one in the ATLS will tell you to do these Foley catheter insertions to control the bleeding. But if you talk to the surgeons in Venezuela who have been dealing with gunshot wounds over the last 50 years, also as a result of tremendous violence, they claim this is very effective. And the surgeons in South Africa and Cape Town have written a significant amount of papers about the effectiveness of managing actively bleeding, exsanguinating, penetrating injuries of the extremity and even of the neck by placing these catheters, especially in areas where you cannot place a tourniquet. This is a rather effective way of controlling hemorrhage. And this is one of those things that if you look at how you manage this hemorrhage in places where there are more resources, they are not as resourceful as some other places in the world. So the experience of the Pan American Trauma Society was something that allowed us to then move forward on a number of things in global health. We were able to bring the Pan American Trauma Society to the University of Pittsburgh, and for many years, we were in charge of enhancing a lot of the activities to the society, and we were able to create courses with the help of surgeons from all over America, North America, Central America, and South America, skilled surgical skills trauma courses, ultrasound trauma courses, quality of care. Charlie Mock helped us using some of the courses that he developed to the WHO. Each and each one of these contributions made the Pan American Trauma Society a real hub for training in trauma. And for many years, we were engaged in trying to collect data so that we could actually understand the burden of disease, of trauma disease in Latin America. These courses were tremendously effective. Over many years, the Pan American was leading the dissemination of quality improvement courses. These were done in many countries in Latin America. And right now, the Pan American Trauma Society offers these courses almost in every country in Latin America. For many years, we had tremendous admiration and respect for the role that nurses played in trauma care. And we involved the nurses very early in our society. And we also participated in the creation of training programs for nurses through the Pan American. So these go back to the very essence of the G4 Alliance, to the very essence of bringing a team of people trained in surgical care. It is not just about being surgeons. It is not just about doing operations, what is critical for global health and surgery. It's about building teams. It's about putting together the skills of the team itself, what actually provides the best care. We are proud of having always involved the youth, and this is something that I like to encourage, that those who are interested in trauma or they are interested in emergency surgery become members of the Pan American in Latin America, because we continue to stimulate their participation. We have opportunities and scholarships for them to learn. We create research opportunities for them to interact and work in different countries. And we continue to learn. The best trauma surgeons in the world are in Colombia because they are the guys who've been dealing with tremendous injuries over so many years. So I love this word, adroit, refers to the person's ability to effectively and efficiently navigate challenges, solve problems, perform tasks with dexterity and expertise. That is a surgeon by definition. Someone who is adroit is characterized by their agility, resourcefulness, and quick thinking, not just operating, but quick thinking. I think that's why I find trauma surgery the perfect intersection with global health and with global surgery. And one of my favorite words is not used very frequently, is the word adroit. And I like to be able to say that we like more adroit people in global surgery. We were lucky because the NIH began to provide funding for trauma programs internationally, and we were able to secure a few of these programs. And over the years, the University of Pittsburgh has been successful in securing grants in trauma for global health to the tune of about $6 million. And over the years, we were able to do these programs in Colombia, in Guatemala, in Paraguay, and most recently in Kenya, all related to how to improve trauma care, access to blood transfusions, safety to blood transfusions, informatics in trauma, all the things that we thought were important to create trauma systems in Latin America. Through these grants, we were able to bring surgeons from Colombia who didn't need to learn how to operate. They were good surgeons trained in their own countries, but they came to the University of Pittsburgh to engage in masters of research and learn how to write grants, learn how to do projects long-term. And many of these Pittsburgh-trained Colombian surgeons went back to Colombia and are now actively generating new knowledge, actively generating research and doing clinical studies in trauma. Over the years, this is perhaps one of the surgeons that I admire most in the world is Alberto Garcia, who is one of the surgeons that I worked with for many years in Colombia, and we were classmates in medical school. So again, it all starts with a personal relationship. It was my ability to talk to Alberto as a brother, almost as a friend, that we were able to participate in many, many research projects, and we have been able to work together on a number of challenging sort of critical problems in trauma care. And we, I think, have created a very productive partnership between the two institutions for many years. This is the trauma center in Cali, Colombia. This is a war hospital. For many years, Cali was probably one of the most dangerous cities in the world, especially when it was punished by the drug cartels of the end of the 90s. And in Colombia, there were never resources. Every weekend, patients were left on the floor because there was no place to take care for them. And maybe they will survive the initial gunshot wound. This is a Saturday morning at a trauma bay in Cali. Most of the patients come transported in motorcycles. If you see their feet are dragged against the asphalt of the road, so they can never walk again because they are driven in a motorcycle. That is the pre-hospital transportation in inner city hospitals in Cali. Patients get injured with the stab wounds to the heart and their chest. They are dragged in these motorcycles. They come to this trauma bay, and we take them to the operating room as possible, as fast as possible. And second-year residents in Cali are so swift at what they do that they are able to do these injuries to the heart, like some of the residents do hernias in other places of the world. Again, this is essential surgery in Cali, Colombia, for many years. And this is one of these areas where we were able to interact and train. A lot of the principles of damage control is something that the Colombian surgeons have become masters. They do tremendous difficult cases with intra-abdominal shunts, and over the years, they have been tremendously productive. For many years, the Colombian surgeons have participated in a number of academic activities throughout the world. They are always presenting the American Association for the Surgery of Trauma, perhaps one of the largest areas of damage control in the chest where presented by Dr. Garcia. He has shown how you can control the bleeding of a injured lung by partially clamping the pulmonary artery, by leaving that catheter inside the heart, the chest for 6-7 hours until they control the coagulopathy, taking the patient back to the open room. And you can see here how this patient is in the ICU, waiting to go back to the open room with this clamp in the pulmonary artery just to control the bleeding, to then do a completion partial pneumonectomy later on. This is the kind of care that trauma surgeons in Cali have been able to share with the world, thanks to their ability to, and you can see the pulmonary artery clamp pulsating while the patient is getting ready to go back to the operating room. Their data is impressive. Their experience is something that they have shared with the world, and they have shown tremendous techniques of how to control the bleeding in the lung without the staples, without the expensive equipment, just with their ability. Let me just move quickly. I don't want to spend a lot of time. I'm already half an hour into this presentation. I thought it was going to be a little shorter. When we talk about global surgery, we always like to understand the mechanisms of disease. As a trauma surgeon, we learn how inflammation, injury to the tissues, and the response to coagulation factors sort of explain how people die of multiple organ failure. Well, in global surgery and trauma, we like to look at mechanisms of disease in a different way and understand the determinants of health. And in trauma, you realize that there is a lot of other things that happen in the society that makes our lives very difficult. Racial disparities, interpersonal violence, personal aggression, socioeconomic conditions, all these things are part of what we see as trauma surgeons. And we as global health specialists need to understand how important each and every one of these factors are key. That it's not just about operating. It is not just about putting the clamp in the right place. It is about understanding the global challenges of what it takes to take care of a society, what it takes to provide economical well-being. And this is perhaps what I think is where everything comes together. Penetrating trauma, to me, is one of the greatest challenges of surgery in Latin America, but it goes beyond that. It affects all of us. The United States is perhaps one of the places where people die most often from gunshot wounds. It is one of those things that should make us shameful of the fact that even in the United States, we're not able to provide safe surgical access because we don't know when the next multiple shooting event is going to happen. So from the social viewpoint, we are all in crisis. Access to surgery because of the tremendous impact that gun violence and multiple shootings. It is a major epidemiological crisis in the United States. This is global surgery. This is global health. And when we are trying to figure out how to improve healthcare in Africa or in Colombia, we need to understand that we're not doing a great job improving healthcare in the United States, and we cannot fix these problems. So I want to leave these two little slides for us to reflect on the effect of many political issues, many societal challenges that made surgery a crisis, even in countries who have all the resources. This is a very old slide. I cannot find a new slide about this. This is from 2010, where they compare the rate of homicide in the United States cities with the rest of Latin America. And the same chance you have of dying of a gunshot wound in New Orleans is that of Honduras. In Colombia, it's the same about Miami, but Mexico now is about 10 times of what it was at that time. So the social impact of violence is something that is quite serious and that we as global health surgeons need to understand. I'm just giving you an example of one of our trainees that came to Pittsburgh and was able to go back and collect data on homicides in Cali. And this is Alvaro, who showed that if you close the bars in Cali, you actually save lives by diminishing the amount of time people have to drink alcohol. And And his data, he showed that every time the mayor of Cali closed the bars at 1 o'clock in the morning, instead of 3 o'clock in the morning, several lives were saved every time they did that. Andres is another fellow from our Fogarty program who is a neurosurgeon who did tremendous amount of training on pre-hospital care in Colombia and on decompressive craniectomy. So global neurosurgery, global neurotrauma is one of those areas that needs to be further developed. I just came back from Malawi. We spent a few days visiting some of the hospitals there. Half of the hospital is occupied by patients with sequela of traumatic brain injury that they have no place to go. So training families to provide rehabilitation for traumatic brain injury may be a solution to improve global surgery in some of the places that are right now suffering for a tremendous incidence of traumatic brain injury due to motorcycle injuries. Is perhaps the greatest aggressor right now in countries with low middle income access. Motorcycles have become the greatest threat on injuries and increasing the demand for care. I'm not going to spend time. This is the work that Sabrina did in Guatemala. She put a trauma registry in Guatemala City, one of the main trauma centers. And we are very proud of the work that Sabrina did in trauma care. I'm going to finish by perhaps with a sad note, but I think it's kind of a call to reality. In 2017, I was invited to participate in putting together the last report on global health that came out of the National Academy of Science. And when I was participating in this group, trying to come up with a report, that was the time that the elections in the United States took place. And even though most of the people writing the report thought that Hillary Clinton was going to be president, we were surprised when in November, when the document was almost finished, that it was Trump who was going to be president. And during the last few weeks of November, we were asked to travel back to Washington to rewrite the report because they didn't think that Trump would read any of these. We thought that he was going to read no matter what we wrote. But during this time, the report was changed. And unlike the report of 1997 that was produced for Clinton, or the report of 2007 that was produced for Obama, the report that we did was totally changed with the idea that the Trump administrators will look at the advices of the role of the United States in global health. And when you see these red arrows here, these were the only places where I was allowed to insert a little bit about essential access to surgery, because at that point the report changed, and we were told that we needed to concentrate on these 4 issues and trying to develop the economic aspects of global health. So it was a little frustrating. It was quite interesting to see that global surgery at that point was just a tiny little aspect of the world of global health from the funders' viewpoint, from what the NIH, the CDC, and all the USAID have been looking through the government and how they needed to change because of what was happening in the literature in the United States. I think I'm going to finish here. The data that the Lancet Commission put together has told us that we need to provide timeliness, make it available and safe and affordable, and we need to provide this to more than 5 billion people. I think these are tremendous challenges. I think we need more data because the Lancet Commission data is not perfect and it has tremendous limitations. So we need to go to the field and work at the field, collect data from the field, and improve the models that have been put together. The models and the data that we know today from the Lancet Commission cannot be not to be generalizable, are limited for some regions, and there are tremendous inconsistencies. So go out there in the world and understand that the p-values of international research in global surgery has to do with the ability of identifying the problem and working with the people and creating effective partnership and being very patient and understand the population you go to and being very diplomatic with 2 Ps all that to have the leadership that is needed. And the leadership that is needed it's special. It's not about being the boss. It's about leading in any situation with or without authority, with or without allocated decision rights, with or without designated followers, with or without a proven set of traits or characteristics, and in conditions in which, if there is no agreement, we may not even know what the right answer is. So I think that to be an effective executor of improving surgical care in the world, we need to learn about leadership as well. And I leave that as a challenge for the young people in the audience. I think I'm going to stop here with a phrase of Galeano. I don't want you to think that global surgery is not achievable as an ultimate goal. And when I Googled global surgery yesterday, the word utopia came on Google. And this is a phrase of Eduardo Galeano, who's an author from Uruguay. Utopia is on the horizon. If I move 2 steps closer, it moves 2 steps farther away. I walk another 10 steps and the horizon runs 10 steps farther away. As much as I may walk, I will never reach it. So what is the point of utopia? It is for us to keep walking. Thank you very much. And I'm sorry that I kind of went over my time a little bit. I think I'm going to stop at this point, and gracias for the invitation. Appreciate being part of this group as well.
Thank you so much, Dr. Puyana. It was really, really, really nice talk. Of course, I clearly identified with all what you just mentioned as I was trained here. You remind me of my days as a student in the ER, and I definitely agree that there is still a need of much improvement. Thank you so much again. And I don't know if anybody else in the audience have questions for Dr. Puyana. Please raise your hand. Dan, I think you have a question.
Juan Carlos, a wonderful talk. Thank you very much. And, you know, we're always looking for tools for our advocacy and directions that our advocacy could go. And I was struck by your comments about the impact of motorcycle injuries on traumatic brain injury and the rise of this. And I'm wondering, where do helmets fit in on that? Are helmet laws effective? And is that something that we, as a neurosurgical community, should be advocating for greater enforcement of helmet laws or enactment of helmet laws in LMICs because of the impact on traumatic brain injuries? I'd love to hear your thoughts about that.
Absolutely. Starting in Pennsylvania, where we have no helmet laws.
Oh, you know, one of these LMICs like Pennsylvania.
Exactly. But yes, from the preventive viewpoint, there's no question that interventions like that are the most important thing we need to do. What I was impressed about Malawi is that even though not everybody wears a helmet in Malawi, but what I was impressed is that the hospital is overwhelmed right now. The beds are occupied by patients who have chronically disabled because of TBI. So this is going to continue to compromise access to other care because the hospital is always full with these patients who cannot go anywhere because there is no rehabilitation. So it's both. It's pre-hospital preventive intervention and post-hospital chronic care for disabilities. So we need to advocate through the whole spectrum of a trauma system, from pre-hospital care all the way to rehabilitation.
Thank you. And I think that's where we can be very effective, like we were with the folate fortification
absolutely.
resolution of advocating for action that will redirect care resources to the areas that really need it. And pre-hospital, post-hospital, that can be a big help. Thank you.
Absolutely.
Serena, I think you also have a question.
Thanks, Carolina. Juan, this was excellent. I'm so glad I stayed awake well beyond my bedtime here in Amsterdam to attend this talk. And I really want you to be one of our PC outreach speakers for our fall meeting. I mean, this is just spot on. One of the things that struck me about your presentation was just how insightful it was and how unapologetic it was around bringing a really important critique, social critique, and talking very explicitly about the role that violence plays in traumatic injury. And what I've noticed is that here in Europe, the traumatologists that I work with and I've engaged with are that kind of explicit critique. It doesn't come to the surface, and it really gets divided between the humanitarian specialist and the rest of us. And so I guess my what I want to get from you is just some feedback about, you're heading up the Royal College here in Ireland, and you're bringing in this really, in my opinion, a really much needed and long overdue fresh approach to this kind of dialogue. But what could be something that, like someone like me who's an ally to what you're trying to do, what can we do here in Europe in terms of the way they like to divide it, the way they sort of don't want to talk about violence explicitly, like, there's humanitarian and then everybody else. So I guess I just want to hear a little bit more about that. And that could be a bit political, but I would appreciate it. Thank you.
It's a difficult question. I'm very familiar with the way trauma care is provided in Europe, and the essential surgery for trauma care in Europe is very different than the United States. I have been too many times at 3 o'clock in the morning looking for a mom in my emergency room at the University of Pittsburgh to tell her that her son is dead because he was involved in a multiple shooting. When you do that so many times that it breaks your heart, and you avoid that to give those bad news, then you connect to the humanitarian aspects of violence that thank God a lot of European trauma surgeons never have to face, because in Europe people don't face these. So I think it's a little bit of the personal experience that everyone has. On the other hand, the surgeon taking care of any of these patients need to be aware of the environment in which these injuries occur. And we cannot be just operators. We need to be public health specialists in understanding the determinants of health. It happens that those are different depending on where we go. And we need to learn from each other, that's for sure.
Thank you. Key, I think you also have a question.
Hey, Juan.
How are you?
Good. Congratulations again. And I was actually joining for the Latin American Working Group, and I was pleasantly surprised to hear your lecture. It was awesome.
Thank you.
Couple of thoughts. One is someone had talked about helmets. So when I was in Cambodia, the helmet rate is like 20%. So we collected data, and then we actually wrote an op-ed, and we met with some of the government officials, and they in fact passed stiffer helmet laws in Cambodia as a result of that. So I'm now thinking, given the folic acid fortification resolution effort, the grassroots, I wonder if we can talk about a helmet resolution. Anyway,
it's a worth fight. It's a worth fighting for.
Yeah. So anyway, but I don't know how much time we have, but Tato is on here, and there's a executive board meeting of the PAHO, member states in just in a couple of weeks, and we were trying to get surgical care on the agenda, which they'll decide, and then it will show up on the regional committee meeting in the fall. And I just wanted to maybe, I don't know if this is the right time to do it, Juan. I didn't want to take away from all the questions that they have for your beautiful lecture. Carolina, you tell us whether we have time at the end to discuss it. I'll stay on a little longer if we have to. Okay, I'll leave it up to you, Carolina. But anyway, Juan, fantastic talk.
Thank you. Thank you. Good to see you again.
You.
Yes, we have two more people, and then we can go back to that topic. Ruben?
Thank you. I'll be brief since we also want to discuss the PAHO regional meeting, but just a pleasure to hear your lecture. Thank you so much for your work before. I love the fact that you reminded us that global surgery isn't, you know, the resolutions or the conferences or meetings is taking care of people. And that's where we should draw our strength and messages from in order to move forward. And the question at the end was amazing. I just have two things. One is we'd love to have your help in getting more of the trauma community engaged in with the G4 Alliance, because we can, I mean, it is, we're advocating for social care, so we want to, you know, we're talking about the helmet resolution. And all, there's definitely work that we will be so thrilled to participate in. And the other one is, you know, after the Zinco resolution, Geneva, and it was thinking what next, right? So there's a sense that we need a call to action. From your experience and having training in Colombia and later on in the United States and Canada and moving on to Europe, what would be an ideal call to action that would unify the global surgery community that ChatGPT will be happy with?
We should ask that question to ChatGPT. I was impressed with the answers they gave me, but I was kind of playing with it last night when I was trying to update the slides a little bit. I truly believe that the trauma societies that are not just in the United States are better equipped to deal with the global surgery aspects of trauma. So AAST East, they're very self-centered on the needs for the trauma care of the patients in the United States and Canada. There's nothing wrong with that. We learn from them, and thanks to ATLS, the whole world knows about trauma. But the reality is that 75% of the world cannot apply what ATLS is teaching, because in district hospitals, there are no CT scans, there is no blood. So ATLS is fundamental for us to learn what is the optimal care of the trauma patient. And then we need to figure out how to do the essential care based on the resources that we have available. The neurosurgeons have done an amazing job about that. They do stratify protocols. The key has worked with Andres Rubiano on providing care for trauma patients with traumatic brain injury when you don't have an ICU, when you don't have an ambulance, when you don't have blood gases, when you don't have intrapressure monitoring inside the brain. We need to do that for all the aspects of care and make it available to everybody, so you don't charge $800 for a trauma course or $2,000 for a DSTC course. We need to make these courses free, which is what WHO is doing, what Rob Noy is doing through the trauma, and what the Royal College is doing to the surgical hub. But we need to do it contextualized to the reality. I mean, if we were going to do ATLS in the hospital that I visited in Malawi last week, half of the things ATLS expect you to have, they're not there. So we got to figure out how to learn with what we have in the places where we're practicing.
Thank you, Maria Camila.
Sorry. Good afternoon. Thank you, Dr. Puyana, for your presentation. I am also from Colombia. And I have a question because in many of these Latin American countries, we have like a maldistribution of the health personnel, the health providers of the surgical care. Yes, surgeons, obstetricians, traumatologists, workers. So I think almost the 80% of the municipalities in Colombia do not have access to one health provider. So my question is, in your experience, what is the first approach to change that panorama? Should be advocacy, capacity building, resource mobilization.
I have been in Ireland only for a month, and I'm trying to read every night a little bit of what they have done over 20 years in Africa. One of the things that we learn about workforce is that we cannot do task shifting. Task shifting, it's impossible to do when there is no one to shift the task to from. We need to do gap filling. That's the first thing I learned from when I was there in Dublin last month. And that is something they have done very well by training people to do surgery, even though they're not surgeons. Clinical officers in Malawi take care of patients without having a full 7 years residency program in trauma. How they do it, I'm sorry, in surgery. How they do it safely? Because they are mentored, because they're monitored, because they are sort of connected. And when they have difficult cases, they are supported. Now, this is not perfect. But if in rural Colombia, in Putumayo or in Caquetá, when some of the places where surgeons don't want to work because it's too far, it's too rural, we need to find a way to fill that gap and create training programs that are less sophisticated, less extensive time-wise, but still safe and effective according to what is needed. And this is an example of that is something that the Royal College of Surgeons developed through something called Cost Africa. And I can send you the information because they develop curriculum to teach people to do essential surgical care without being surgeons. Clinical officer surgical training, that's what Cost means. Cost Africa is an example of that.
Thank you.
Thank you. Tato Uribe?
Hi, everyone. Thank you for the invitation, Dr. Puyana. You for the fascinating talk. Sorry, I'm also in transit. And I couldn't agree with you more. I agree that a strong and robust trauma system, and I'm going to remove my camera and put the phone down so I'm not in an accident. The backbone of a strong surgical system overall. So I would love to get your feedback. Our national surgeon institution strong component of trauma. Something working with it from currently, and this is an area we're working with Dr. Salame, and I think the whole region has a great potential to strengthen their trauma system. A role model for the world that you just mentioned. So I would love to get your thoughts in moving that system and those things that you've learned through policy and to enact long-time change. Over, and thank you again.
Tato, no te entendí la pregunta. La señal está muy pobre. Can you repeat it quickly and briefly, see if I can get it again?
Oh, una disculpa. Yeah, it was more of a comment. It was I couldn't agree with you more that the backbone of a strong surgical system is a strong trauma system, and particularly in Latin America and in other settings that you guys work with in global surgery. And I would love to get your insights and your feedback in the national surgery, anesthesia, and obstetric plans that we have the opportunity and the privilege to collaborate with other countries to make sure that this is reflected in the best manner possible. We're currently working with Dr. Salamea in Ecuador, and his insights have been invaluable. So just wanted to thank you for this presentation and the work you do. Over.
Thank you. I think health systems could learn a lot of trauma systems. I think that if we were to develop a rudimentary trauma system, that may be the perfect building block in which you can improve upon other health systems, because it's got every little part, and it needs to be done according to the resources. But what we do in Kenya right now is, for example, developing transfusion systems. So health systems are built of other systems. A health system without transfusion won't work. A health system without trauma won't work. So if we develop little systems and kind of join them together, I think that's an effective way of making the overall health system growing. And I think it's gonna be a long time. We'll probably be all dead before we reach that, but there's no reason to stop.
I think we're almost over, so I'm going to give Diane Urquiaga the last question, and then we will see if we can. Some of us would like to join the conversation that Key proposed about PAHO. So Diane?
Yes, hi, that's a comment. Thank you very much for your presentation, Dr. Puyana. And I think that having all these organizations here in this presentation, I think working together, developing strategic alliances to help provide to develop capacity building, I think it's most important. I know smoldering work in the South America region. We have helped build the neonatal units. We have helped build intensive care units, OR. So maybe working together, we can, because we do have the funds. I mean, all these organizations together, we do have the funds. It's just working more in alliances and building these strategic alliances to work towards resolving these issues, no?
Absolutely. The key word is sustainable. So we got to keep working together. I agree.
And training the locals to be sustainable. That's the key word, exactly.
Yeah.
Well, Dr. Puyana, thank you so much for your presentation. Again, it has been extraordinary talk and discussion. I don't know if do you want to provide just few words to say goodbye to all the people, and if the ones who want to join key for the conversation about PAHO, if you have a little bit more time, we can talk about that. And then, of course, in our next meeting of the working group that is going to be on June 21st, at the same time, you're also welcome to participate. So, Dr. Puyana.
No, muchas gracias. I'm impressed with the Europeans who stayed up at midnight. Thank you for your presence, and it's a pleasure to be part of this group. Thank you.